Welcome to Healthcare Algorhythm. I'm Dr. Will Strimel. If you want the real story behind today's healthcare challenges and the strategies and technologies people are actually using to solve them, you're in the right place. Short conversations, clear insights, practical takeaways. Let's get into it. Hey everybody, welcome back to the Healthcare Algorhythm. I am Dr. Will Strimel, and as I have mentioned in the past, my cardiology practice is based in the hospital. And one thing that I see over and over is this. Some of the most important care that happens in our system doesn't happen in the hospital. It happens after the patient gets home from the hospital, because that is where medication changes have to be implemented, follow-ups have to be, kind of followed up with. People have to go to the doctor. And importantly, families are trying to piece a lot of this together for elderly patients. It's a very vulnerable time for someone who's just come out from a serious illness. Well, today we're going to talk to someone who is working right in the middle of that reality, who's caring for high-risk patients in the home and helping bridge that gap between what happens in the healthcare system and what actually happens in the patient's day-to-day life. It's my pleasure to be joined by Dr. Ricardo Febry. He's the founder of Care Associates, a physician-led organization delivering home-based primary and transitional care to high-risk medically complex patients. Dr. Febry, it's great to have you with us today.
Thank you. Thank you for inviting me. It's a pleasure to be here having this conversation with you.
So you have been practicing this space for a long time, and I imagine have seen a lot of changes in the way care is being delivered. But just start a little bit by telling us about Care Associates, what you do, and what was your inspiration for taking on this challenging problem?
Well, it's a long story, and I'm not going to bore you with all the details, but I was a traditional internist after I finished my training at Tulane University and was in a traditional practice in New Orleans for, 7 or 8 years. And I opted to just leave the practice and go on my own and start a new opportunity that came to me, assuming care for about 400 nursing home patients from a doctor that was retiring.
Okay.
And so I figured that for me, that was a novel approach because I was going to be able to run that operation from my home in a home office.
Okay.
This was back in 2001.
Sure.
And back then, the technology that we have today wasn't even close, right? So my first technology interest was in a little product called Pocket Billing. It's no longer in existence, but it allowed me to build my database of 400 and something patients and allowed me to be able to track them. When was the last visit? Program it so that it would tell me who hasn't been seen in more than 30 days. The nursing home population by definition tends to be high risk. So you want to see them at least once a month. And so that's how I started on my own by myself. Within a year, hire a nurse practitioner, and after that, year later, hire a second nurse practitioner, and then Katrina hit New Orleans in 2005, and it kind of wiped out, all the nursing homes, and by then we were expanding into doing hospital medicine. Our community hospital where I operated at that time, the hospitalist concept had not yet arrived.
Sure. It was
But we knew that there was a demand for that. Yeah, so we knew there was a need for that, and a lot of primary care doctors that were served by that hospital were asking for that service. So that was our first diversification. We went from being primary care doctors for this nursing home population. We expanded it because we were following our nursing home patients into the hospital.
Mhm.
And because we weren't burdened by a brick and mortar primary care practice, we had a lot of flexibility. And so we, at any point in time, we would have, 8 or 9 patients in the hospital. And so we started approaching other primary care doctors to see if they wanted us to do the coverage for them. By then I had hired my first physician colleague. And so we started the concept, this faculty started looking at us, the administration started looking at us, and they liked the concept. And a few years later, back and forth, we ended up signing the first contract with the hospital administration to run a hospital service.
Mm-hmm.
And at that time, maybe today is still the case, Medicare was developing that concept of penalizing hospitals that had a high 30-day readmission rate. So the big driver of readmissions was the nursing home. So we were able to demonstrate with our program that a nursing home, a readmission rate was around 10%, where the state's readmission rate was 25%. So the hospital like that, we maintained that relationship with the hospital for, I don't know, 15 years. I grew the practice to 5 hospital doctors, 5 nurse practitioners in the field working in skilled nursing facilities. But there was still a missing link for me in terms of, why are these people ending in the nursing homes? Once you work in a nursing home for a while, you realize that it serves a purpose in society, but there's a lot of people admitted to nursing homes that could delay that admission if the families and caregivers had a different set of tools in their toolbox and resources to be able to keep those people at home
Right.
longer. Uh,
Which is where most
and in a
seniors
safe
want to be. Let's be real.
Yeah, I mean, the nursing home is the last resort. You really, nothing beats being at home with your family and care by the people that love you, even with the shortcomings, when they're short-handed or, they don't have all the resources necessary. It's still better, in my opinion, than landing in a nursing facility. So as my practice evolved, we ended up merging with Tulane University about 4 years ago. Let's see,
Okay.
2020. We merged into Tulane, and after 3 years assisting Tulane with the integration of our operations into their midst, I decided to leave. I had founded a hospice agency several years prior. In 2004. We founded a hospice agency also. That's two separate operations, right? So this is what I think this conversation can be productive, is showcasing the disjointed system, right? So
Absolutely.
when I left Tulane, I went back into the hospice agency full time, and trying to figure out, how can we make this work better for the elderly people in our community. And what I realized is, I have all this staff that are, required by Medicare. We need to hire nurses, we need to hire social workers, we need to hire aides, we need to hire clergy people. It's a whole program of professionals that are sitting there idle, unless you have a big census, right? And so trying to have a conversation with people about end of life care when they don't need that conversation, there's a lot of elderly, frail people out there that, are looking at, 5, 10, 15 years of productive or enjoyable life. I opted to change the organization completely. And we did in 2023, we did a revision of the entire concept. We changed the name of the organization. We added lines of service that were more in tune with what the elderly population needs.
Mm-hmm.
What they need is assistance. They need someone to come in and, provide them visits at home, and not only provide them visits at home, but provide a social worker that can point to them, if they need, if the social worker can do a financial analysis, psychosocial analysis, and an analysis of what are the family resources available and the community resources,
Mm-hmm.
then those social workers and case managers can then put together a recommendation on how to keep that person at home longer if maximize all of these resources in a cost-effective way, right?
Yeah. And
That's a service that you can't do from a primary care position, just billing fee for service
just based
to
on volume, right?
Medicare.
And
And
as you talk through that, one of the things that makes me think about, first of all, the healthcare system fragmentation is real. But when we think about that, we just often think about, okay, there's different hospitals, different doctors, they're in different locations. But you bring up an even more interesting challenge about the fragmentation of the needs of the different stakeholders. So as you're talking, I'm thinking you're going through this. Your stakeholders are the hospitals, then you bring in university, right? So education, the nursing homes, the payers, the patients, the families. How did you think through navigating all those? Because you can imagine you put those all on a Venn diagram, there's going to be a lot of places where their sort of goals are not necessarily going to intersect.
so what I did was I did a lot of research on this in terms of how can we blend all of this in a cohesive way. There's
Yeah.
some things that you need to be careful with the regulation, federal regulations, but I had never seen an organization like ours that included medical practice combined with a hospice agency with all
Right.
of these healthcare professionals in the payroll. So I figured out, at that point, this was about 2 years ago, Medicare Innovation Office came up with the GUIDE program, which is a program for caregivers taking care of dementia patients, right?
I
And
just heard about that recently.
in
Yes.
the request, yeah, and in the request for proposals, it describes very distinctly that they prefer organizations that would work with one tax ID, right?
Hmm.
Handle all of these contractual obligations through one tax ID. So
Okay.
I saw that as a green light to say, well, then I can take my medical practice and put it under one tax ID with the hospice agency. We can change the name of the organization and take hospice out so that people don't think that we're trying to talk them into dying and stuff like that, and rather talking them into looking at us for the value proposition of having these healthcare professionals trained in case management provide services outside of anything related to end of life or hospice,
Yeah.
right?
We're
And
later
more related
the
to the
later stages
clinical
of life.
aspects. Exactly. And the caregiver support. So the GUIDE program kind of taught us and showed us how to coordinate all of these moving targets. We have been able to build in the technology space, we have been able to build a platform that builds care plans, that tracks, the credentialing for guide. That I mean, it's really we have been building it slowly to fit our needs. We're not buying software from another company, and we're building it from scratch, and it fits what our needs on a daily basis. And when there's a need for a particular technology support, they present that need to me, and I design it, and I code it, and boom, we have it operational. So what he has are you there? Did I lose you?
So can you hear me?
Yes.
I have no idea what happened there. My system just completely cut out. That was on me, but that's okay. I'll be able to kind of blend these together. You were basically, we'll let me record again. I think we actually are still recording. Okay, perfect. Good. It even kept the recording going. Outstanding. Okay. So you were mentioning that you were just starting to build these things as you go along. So just kind of pick it up from there.
Yeah, so we started building our databases to track all this information related to the obligations we had to the Guide Innovation Office through the contract that we got selected to be a guide provider. Is the bottom
Okay.
line. That uh, becoming a guide provider or participant has certain requirements and conditions that we had to meet that require managing a lot of incoming data and a lot of outgoing data and care planning and all of that stuff. And there's really no that I can identify when we got selected for this program. There was really no off-the-shelf platform that could solve all of those problems.
Yeah, so
And I
I
have been
imagine there were a bunch of operational issues that you had to solve, but maybe just give me a sense of, okay, you put this together, you had your goal, you had your vision. What were the first one or two challenges that you really had to tackle from an operational standpoint? Obviously, the
well,
clinical
it was
care
it
part.
was it was it was changing the mindset of the staff in the hospice
Interesting.
agency to start looking at themselves not as a end of life care provider, but as a provider of care and coordination and support for elderly frail patients and their caregivers. And that if at some point or down the line somebody enter that area of terminal, care, then we could do that too, because that has been our expertise for the
Hmm.
last, 25 years. But changing that mindset was a major challenge. But I succeeded in doing that. I have very good staff who is very open to innovation, and they were very receptive to the concept. And I think the concept is proving itself. We've been doing this now for guide program for 1 year, the redesign of the entire organization for 3 years now.
Okay,
And
wow.
so we are now able to go out and talk to people who are caring for people with dementia, or they don't have to have dementia. They can be just elderly frail. So we're focusing on the people who are homebound due to age and frailty, right? And so by doing so, we also trying to, we compete with the primary care doctors in our community,
Hmm.
right? Who have to deal with a brick and mortar operation. And what we do is we go and we partner with those doctors and tell them, send us the people that are having a hard time getting to your office and that you had not seen in over 6 months or 12 months because it's very difficult for them to come to an appointment. That's the population, that's the niche that we're focusing in care associates. That's why it says care associates, senior services integrator. Well, it's senior services for people who are frail and homebound.
Right.
Integrator, right? So if you are in that category, then we can definitely make a significant impact in the quality of your care at home without having to have the burden both for the patient and their caregivers, the burden of having to climb on a car, drive to an appointment, or if you have an emergency or an urgency, or even more simply than that, I'm sure you're aware that many practices will not refill a prescription if you haven't been in the clinic in
Absolutely.
6 months or 12 months. The different practices will have different thresholds, right? And there's a reason for that. They there's an overhead to cover, and if you can't make it to appointments and they keep refilling stuff, then they're still burdened by the risk, right?
Absolutely. The liability.
Deriving the benefit. So there's a reason, a justifiable reason for doing that. This is not a criticism, right? But it is an example or evidence that there is a population there for which coming to a doctor's appointment is burdensome, and we can fit and fill that niche by not forcing you to come to us. Instead, we come to you.
Come to you. Yeah.
And
So
we make ourselves,
as
yeah,
you,
we
as
make
you start as you made that shift, then how did that inform your sense of building the technology, right? What were the key components that had to be different because there's plenty of technology in healthcare, no doubt,
there is,
but not
and I
all of it
can.
makes our lives easier. So were there certain things about what you were doing that made you design in a certain way, or talk to
Well,
developers?
the first thing is the electronic health records. They're not designed for this type of practice.
No.
The electronic health records are designed to have a calendar with a schedule. Monday at 9 a.m. Joe Blow is coming. Tuesday at, so it's not designed for the type of scheduling that we needed. I needed a scheduling system where I could see all my patients and track when's the last time they were seen, and put them on a schedule. Like if I want to, depending on where they are, what's their level of care. If they're in a nursing home every 30 days, if they're in assisted living every 60 to 90 days, if they're at home, on demand, and every 6 months. So to be able to create that, I had to design my own tools. So I started doing these designs years ago with different products. But I tell you, in the last maybe 8 or 10 years, a creator to build my own databases.
Wow.
It's a low code platform where you can go in, and it took me about a year to master it,
Mm-hmm.
but I'm good enough now after all these years doing it. I think that I have built very powerful applications, and they integrate each other. I mean, it's really beauty of it. The beauty of it is that if a staff member comes to me and say, "Hey, Dr. Febry, can you add this to the list of options on this field?" And I just go in
And
and
you
I
do it
add it.
yourself.
I do it myself. I mean, if you go to Epic and tell them, "Hey, can you modify this or Cerner or Practice Fusion?" It's not going to happen,
Well, now I'm
right?
curious, have you looked at it from a standpoint of, if you had this pain point, obviously there's many people in the country who've had it. Have you thought of trying to expand it or develop it further, or
It's a busy organization with just maintaining my own
yeah.
creations. There's a lot of time that goes into supporting those creations. The iteration, the debugging iterations. It's always there. It's for us right now. It works. I'm not at a point there yet today and I don't consider myself a professional, to build professional grade or something that a third party would want to invest money
Right,
in.
right.
And
And
I
you
don't
build
want
it
that
now more out of
responsibility.
necessity.
If I mess it up, I'm messing it up in my own
Just for you,
organization,
right?
and it's my problem, and I fix it. But yeah, I have thought about it at some different times in my career. But when I take a deep dive into it, it's like, no, I'd rather build them for my organization and then use that to differentiate my organization and then sell my organization to third parties, right?
Yeah,
So
well,
I don't want to sell platforms that I build on Soho. I want to sell our organization with its
Is
infrastructure
powered
and
by that.
technology stack that can do things differently than from everybody else.
Yeah, because one of the things I feel is really important, and it's fascinating to see someone who's like working a clinical, carrying a clinical profession in real time and still developing, is that so often, as you gave a little bit of a voice to, the technology that's out there is not built by clinicians and doesn't feel like it's built for clinicians. And
Right.
so that, that's very encouraging to have someone who's actually, you can see the problems up close and then you're iterating and building for them. So yeah, that's
Exactly.
something that we really would love to capture more as healthcare systems evolve. There's a hope maybe tools driven by artificial intelligence will make that a little bit easier, certainly from the coding perspective. You,
Oh, absolutely.
you can, I'm sure you've
Enjoying.
messed around with it.
I'm already enjoying the impact that artificial intelligence is having in my designs. My designs have improved significantly. The debugging steps have been minimized. The use of AI to present a concept and say, this is what I want to do, and this
Mhm.
is how I want the data to flow, and this is how the workflows need to go, and have this platform produce for you a blueprint, and then you just start testing it and building it, testing it, and pushing back. There's a lot of pushback when
Yeah,
I'm using my artificial intelligence provider. I push back a lot, and that pushback has an impact because I mean artificial intelligence is it's really something. I don't know what your opinion of it is, but it's a game changer.
absolutely. But to your point,
You have to learn how to
it's
use
a
it
tool,
effectively.
right? It is a tool, but it's important not to just turn over all of your autonomy of your thinking and
Exactly.
everything to it.
Exactly.
My feeling is the best way to use it is for, it depends on the model. Of course, different models have different strengths and weaknesses, but it's all about, taking your insights, your knowledge, your expertise, and bouncing it off and just, see if it can help you create and you think in a different way. We don't want to turn over the creative influences to these models because in generally they're just, they're large databases. And so this is why it's important, I think, to have the blend of it. So you have a really interesting lens as someone who's an active clinician and really, and it sounds like an active developer. So what do you think, if you kind of look at this in the world that you practice within, what is going to be the biggest changes in the next, say, 1, 3, 5 years from these new technologies that hopefully will make your job easier and, more importantly, patients have better outcomes and their families have a better experience with their care?
There obviously there are different phases to that question. There's if I wear my hospitalist hat, the progress with technology has been very, very positive in the impact that it has had on my ability to take a difficult case in the hospital and review extensive amounts of information that were previously not accessible to me.
Uh-huh.
uh, the use of health information exchanges combined with artificial intelligence helping you, summarize a very complex case and have you vet the information has been tremendous. I think hospital care, and the same applies for ambulatory medicine care. If you have an electronic health record correctly connected to the right sources of data and information. You have these medical record companies are getting better integrating artificial intelligence into their models. Then I think the physicians have a better opportunity to deliver better and more efficient
Yeah.
care.
So from the standpoint of clinical decision support, you're already seeing
Yeah.
significant improvement.
Yeah,
What do you
and
think about the,
particularly at my age, when you're getting older, it's harder to remember stuff, right? So it's not that you're delegating or giving or telling them, do the decision making for me. Is that it can retrieve tidbits of information that may have escaped your mind as another option on how to treat a particular scenario you're facing in the hospital or in the clinic that you may have forgotten about, and you go, "Ah, yes, okay." And once your memory is refreshed on that point, then you take advantage of your experience and expertise to vet that information, right? Because you still have to vet it, right? I don't think that the artificial intelligence will be able to do the vetting for you.
no,
You
and
you have to do the
consistent, what we're
vetting.
seeing right now, of course, it's likely to improve, but it does very well on tests when it's very structured information. but put it into the real world, so to speak. It put it into abstract concepts. It doesn't do as well.
Right, exactly. You have to be careful with that. So I think that in that regard, that the impact of technology is going to be great in the realm of caring for people who have limited access to care because of frailty and because they're homebound and all of that. Again, technology has been a game changer. It's been, in silos of technology, video conferencing, for instance, have had a major impact in the ability to connect face to face with a patient who is homebound. It's getting better by leaps and bounds. And so that's one thing. Should medical schools include in their programs a little bit of software development, a little bit of coding training for doctors so they can use low code platforms to build their own applications? I think that would be a tremendous asset. I think our ability to differentiate ourselves from other practices I have to admit, has hinged on my ability to go in and identify data needs that are not being met by a traditional electronic health record that I can meet very easily with my applications, and therefore give me an advantage tracking information for those patients, contacting and relating back and forth with those patients, being accessible to those patients on a 24/7 basis. I mean, that to me is one of the better impacts of technology in what we're doing. I don't think I could be doing this 20 years ago without the technology that
Yeah,
we have.
and I'm still amazed that you're a clinician, you're a developer, you're a businessman. Like, I don't know how much free time you tend to have, because it sounds like you're really doing a lot for really challenging patients.
I enjoy it. It's I enjoy it. It's my reward comes from the joy of building something that works and that my staff can implement, and the staff comes back. Initially they say, "Oh, this is not easy to use," and then they learn to use it, and then they say, "Wow, this is really great. It's made my life a lot easier tracking all this information." We just built the other day. We built an internal messaging system. We have chat. We have Microsoft Teams, and Teams has chat. And you have all this, but they don't solve the problem for us. We had a need to be able to track and audit incoming phone calls coming into the office, right? Because we were having some situations where people were calling back a day later, say, "Hey, I didn't get a call back." I said, "How can I solve this problem?" And I figured, well, let me create a messaging board. We collect the message, assign it to somebody, and then in the back end, build a reminder. 3, 4 times a day, that person will get an email saying, "You still have a message on the board that hasn't been responded to." Right? And then we rank those messages in terms of we prioritize, and this one should be answered in certain number of hours. And create those rankings, and then track how long it takes for that person to respond to that message. So that took me, I don't know, 2 days of development and testing, and everybody loves it now.
Wow.
And I am now able to see the flow of
Well,
messages and
yeah,
see
which is
what's
communication in
and
our business is the name of the game, right?
keeps everybody on their toes. So it improves customer service. Yeah, at the end, what you want is better customer service. We want our customers, which is our caregivers and our patients, to know that we're listening to them, that we're not blowing them off, and that we're going to treat them like you treat somebody when you go to a fine restaurant, or you want
Yeah.
to be taken care of
So,
and
I
do
don't
it.
I don't really typically come across someone on this show with your unique blend of clinical and entrepreneurial and developing experience. So I'm going to ask you a question that I really don't ask very often, and that is, if you could speak to someone just completing medical school or just in their residency, just about to embark on what is a very different world in terms of the practice of medicine than you and I came into so many years ago, what advice would you give them, if they have this interest of being like yourself, entrepreneurial, building their tools, informing the way that they and their teams are allowed to work with technology?
Well, I would off the top of my head, two pieces of advice would be: learn to master artificial intelligence, learn how to design queries, and learn the pitfalls of artificial intelligence so that you don't get caught. Number one. Number two, learn a little bit about computers, understand how computers and platforms and technology, software technology works. And if you can, learn how to do simple coding with things like Zoho Creator or any other. There are plenty of platforms that you can play with. because you will never find, if you want to be independent,
Mm-hmm.
you have to be able to build your own tools. Otherwise, you're always going to be at the mercy of somebody else. We would not be, I don't think we would be as successful today as we have been if every time I needed a new piece of software, I had to go to a third party vendor
Yeah.
and pay a subscription service for 20 employees. It's the law of economics, supply and demand. You have to be able to invest in technology based on how much you're getting in revenue, right? And oftentimes, you're in a fee for service model, or even in a HMO type model,
Yeah.
you have to be very careful how you handle
About the
the
cost.
dollars. And so, by anybody who wants to succeed as an independent provider needs to understand those efficiencies and needs to know how to bid those efficiencies. There's always someone out there who is going to offer you a better mousetrap for a fee,
Right.
right? Well, it's all tagged on to a fee. And if it's a non-clinician, it's a fee that needs to cover the investors that funded the development of
Yeah.
that platform, right? So I mean, we had early on in the guide program, just to give you an example about the impact of technology. Some company, there have been a few companies that have built these huge platforms for guide to help guide
Oh, wow.
providers
Yeah.
manage the guide programs. And they come and you say, okay, well, what's your business model? Well, it's going to cost you, I don't know, $300 per member, per user, per month, something like that. And it's like you're thinking, you're not understanding how Medicare works and how they pay for this program, So that's the kind of thinking I would give to a young doctor. Always be aware of technology.
Yeah, well, I
And
really
learn how
appreciate
to-
that, because my hope is that these emerging technologies may lead to somewhat of a renaissance of private practice or at least independent practice,
Absolutely.
because I think, there's definitely a role, especially in large academic institutions, for employed models. But I think to the extent that physicians and clinicians can gain some more autonomy, that I think it'll serve everyone well, and especially our patients. And Dr. Febry, what a pleasure speaking with you today.
Thank you.
If anyone's interested in your model or just kind of reaching out to you, how can they connect with you?
We have a website that explains everything that we do. It's care.associates. Very easy. It's not careassociates.com. A lot of people get confused with that. But care.associates explains everything. We have a link there to a booklet that has our lines of services, including serious illness medicine consultation, dementia care programs for guide. We recently went live in January with an adult daycare center for people with dementia, which is a respite option for those caregivers that are still caring for people at home. We have private case management available, and then we have end-of-life care and hospice. So we're a full-service house for homebound elderly people to do from primary care all the way up to end-of-life care.
Well, fantastic. Thank you for joining us. Thank you for the work that you do. I found it very interesting. And keep on coding, right? It's still okay to learn to code, I guess.
Yeah, absolutely. Absolutely.
And thank
absolutely. You. Thank you so much. Have a nice day.
My pleasure. Thank you, everyone else, for joining us. We hope to see you next time on the Healthcare Algorithm. Until then, be well.